everyone. Today we'll be discussing post-traumatic stress disorder, also known as PTSD. In this lecture, we'll be discussing definitions, etiology, epidemiology, diagnostic criteria, a case example, and treatment options. Now, what exactly is PTSD? Formerly known as post-traumatic stress disorder, it's a mental health condition which affects many individuals who have experienced a traumatic event. It can affect anyone regardless of age, race, gender, etc. It was first recognized in war veterans, but it's not only diagnosed in soldiers, and it's held many different names, such as shell shock. Now that we know what PTSD is, simply, what exactly is a trauma? According to the DSM-5, trauma is an actual or threatened death, serious injury, or sexual violence. This definition of trauma is required for a PTSD diagnosis, but there are other definitions of trauma which are pretty important too. Big T trauma generally correlates with the DSM-5 definition of trauma. Examples include fighting in a war, experiencing natural disaster, or violent crime, etc. Small t trauma, however, for the most part does not lead to the development of PTSD and tends to be overlooked. This includes distressing events that are not inherently life or bodily integrity threatening. Examples include divorce, infidelity, etc. Etiology. What causes PTSD? There are a number of pre-traumatic, peri-traumatic, and post-traumatic factors which can contribute to the development of PTSD within an individual. Pre-traumatic factors include temperamental, environmental, and genetic and physiological factors. Temperamental includes childhood emotional problems by the age of 6 and prior mental disorders. Environmental comes down to lower socioeconomic status, lower education, exposure to prior trauma, especially during childhood, cultural characteristics, lower intelligence, minority racial/ethnic status, and family psychiatric history. Genetic and physiological factors come down to female gender and younger age at the time of the trauma. Peritraumatic factors really come down to environmental factors. What was the severity of the trauma? Was there perceived life threat, personal injury, or interpersonal violence? For military personnel, being a perpetrator, witnessing atrocities, or killing the enemy are very strong peritraumatic factors. Finally, dissociation that occurs during the trauma and persists afterward is a risk factor. What about post-traumatic factors? These really come down to temperamental and environmental factors. Temperamental factors include negative appraisals, inappropriate coping strategies, and development of acute stress disorder, which we will discuss in the next slide. Environmental factors include subsequent exposure to repeated upsetting reminders, subsequent adverse life events, and financial or other trauma-related losses. What is acute stress disorder? As discussed before, it's a post-traumatic factor which contributes to the development of PTSD. It's an intense, unpleasant, and dysfunctional reaction that occurs shortly after an overwhelming traumatic event. Now that we know what acute stress disorder is, how does it differ from PTSD? Well, generally, acute stress disorder symptoms last for less than a month. Meanwhile, for post-traumatic stress disorder, symptoms last for more than a month. Now that we know all this, what is the epidemiology of PTSD? Well, in general, epidemiology is the study of the distribution and determinants of disease in a population. There are a number of epidemiological studies of PTSD in the community and in veterans. What is the prevalence of PTSD among adults? An estimated 3.6% of U.S. adults have had PTSD in the past year. Past year prevalence of PTSD among adults was higher for females than for males, with 5.2% of females and 1.8% of males experiencing PTSD. Lifetime prevalence of PTSD was 6.8%. What is the prevalence of PTSD among children and adolescents? There is no epidemiological study that has examined the prevalence of PTSD among children. However, an estimated 5.0% of adolescents have PTSD, and an estimated 1.5% have had severe impairment as based on DSM-4 criteria. The prevalence of PTSD among adolescents was higher for females, with 8.0%, than for males, which is only 2.3%. So far, we've only looked at the prevalence of PTSD across the United States, but what about around the world? Estimates for lifetime PTSD prevalence range from as low as 0.3% in China to a high of 6.1% in New Zealand. But statistics reported from various countries are not directly comparable due to methodological differences in survey administration and sampling strategies. Now for what we've all been waiting for. What is the prevalence of PTSD in veterans? Well, it really varies by the service era. OIF and OEF operations have about 11 to 20% of those who serve having PTSD in a given year. For the Gulf War, about 12% of those who serve have PTSD in a given year. And for the Vietnam War, about 15% of Vietnam veterans were diagnosed with PTSD at the time of the most recent study in the late 1980s. But it's estimated that about 30% of Vietnam veterans have PTSD in their lifetime. But wait, how is one even diagnosed with PTSD? Well, criteria really comes down to age. Criteria differs for those over the age of 6 and those 6 and under. For those over the age of 6, exposure to trauma in one or more of the following ways is necessary for a PTSD diagnosis. Directly experiencing the traumatic event, witnessing in person the events as it occurred to others, learning that the traumatic event occurred to a close friend or family member, and experiencing repeated or extreme exposure to adverse details of the traumatic events, which does not apply to exposure through electronic media, television, movies, etc., unless the exposure is work-related. Another piece of criteria for those over the age of 6 includes presence of one or more of the following intrusion symptoms associated with the traumatic event beginning after the traumatic event has occurred. Recurrent involuntary and intrusive distressing memories of the traumatic event, recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic event, dissociative reactions such as flashbacks in which the individual feels or acts as if the traumatic event were recurring, intense or prolonged psychological distress that symbolize or resemble an aspect of the traumatic event, or marked physiological reactions that symbolize or resemble an aspect of the traumatic events. Another piece of criteria for a PTSD diagnosis is persistent avoidance of stimuli associated with the traumatic event, as evidenced by one or more of the following: avoidance of or efforts to avoid distressing memories, thoughts, or feelings about or closely associated with traumatic events, avoidance of or efforts to avoid external reminders that arouse distressing memories, thoughts, or feelings about or closely associated with the traumatic event. Another piece of criteria is negative alterations in cognitions and mood associated with the traumatic event, as evidenced by two or more of the following: inability to remember an important aspect of the traumatic event, persistent and exaggerated negative beliefs or expectations about oneself or others or the world, persistent distorted cognitions about the cause or consequences of the traumatic event that leads to the individual to blame himself, herself, or others, persistent negative emotional state, markedly diminished interest or participation in significant activities, feelings of detachment or estrangement from others, and persistent inability to experience positive emotions. Finally, for a PTSD diagnosis, marked alterations in arousal and reactivity associated with the traumatic event, as evidenced by two or more of the following, is required: irritable behavior and angry outbursts, reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbances. What is the diagnostic criteria for PTSD in those 6 and younger? In children 6 and younger, exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways is required for a PTSD diagnosis: directly experiencing the traumatic event, witnessing in person the events as it occurs to others, especially primary caregivers, and learning that the traumatic event occurred to parent or caregivers. Similar to those over the age of 6, the presence of one or more of the following intrusion symptoms associated with the traumatic event is required for a PTSD diagnosis: recurrent involuntary and intrusive distressing memories of the traumatic event, recurrent distressing dreams related to the traumatic event, dissociative reactions in which the child feels or acts as if the traumatic events were recurring, intense prolonged periods of psychological distress that symbolize or resemble an aspect of the traumatic event, and marked physiological reactions to the reminders of the traumatic event. As well, one or more of the following symptoms must be present beginning after the events or worsening after the events: persistence avoidance of stimuli, such as avoidance of or efforts to avoid activities, places, or physical reminders that arouse recollections of the traumatic event, or avoidance of or efforts to avoid people, conversations, or interpersonal situations that arouse recollections of the traumatic event, or negative alterations of cognition, such as substantially increased frequency of negative emotional states, marked diminished interest or participation in significant activities including play, socially withdrawn behavior, or persistent reduction in expression of positive emotions. Another piece of criteria for a PTSD diagnosis in children 6 and younger are alterations in arousal and reactivity associated with the traumatic event, as evidenced by two or more of the following: irritable behavior and angry outbursts, typically expressed as verbal or physical aggression toward people or objects, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbance. For all people to be diagnosed with PTSD, the duration of the disturbance must last more than 1 month. The disturbance must cause clinically significant distress or impairment in social, occupational, and other aspects of functioning. The disturbance is not attributable to the physiological effects of the substance or other medical condition. Now, what subtypes of PTSD exist? For those of all ages with a diagnosis of PTSD, a clinician must specify whether with dissociative symptoms or without. With dissociative symptoms, in response to the stressor, the individual experiences persistent or recurrent symptoms of either of the following: depersonalization or derealization. Depersonalization refers to persistent or recurrent experiences of feeling detached from and as if one were an outsider observer of one's mental processes or body. Derealization refers to persistent or recurrent experiences of unreality of surroundings. To use a subtype, the dissociative symptoms cannot be attributable to the physiological effects of a substance or other medical condition. How else might PTSD be diagnosed? With the diagnosis of PTSD, a clinician must specify if with delayed expression. This occurs if the full diagnostic criteria are not met until at least 6 months after the event. Now that we know all of this about PTSD, how can this knowledge be applied? Let's look at a case study. What's wrong with Veronica? Veronica is a 29-year-old woman coming to you after her fiancé urged her to do so. She was a soldier in the army who had served on 2 tours of Afghanistan. Her fiancé claims that she has not been the same since her second tour in 2019. Although she offers little details, upon questioning, she reports that she has difficulty falling asleep, and when she does fall into a deep sleep, she often has nightmares. She agrees to having experienced several traumatic events on her second tour, but she won't provide any details. She isolates herself most of the time because she feels irritable and does not want to snap at others. She claims her new job as a warehouse staff member bores her and gives her too much time to think. Simultaneously, she confirms that she is startled by certain noises and motions. She seems on edge when admitting this, and she confirms that she spends an excessive amount of time searching for threats that are never present. She explains that she has intrusive thoughts about her traumatic experiences often, but again declines to share details of the events. She avoids seeing others from her tour so as to not trigger memories of experiences that she does not want to remember. Now, how do we know that Veronica has PTSD? From the case study, we were able to gather the following symptoms: trauma, sleep difficulties, loss of interest, irritability, isolation, intrusive thoughts, and hypervigilance, which are all symptoms of PTSD. How does the diagnostic criteria confirm the diagnosis of PTSD in Veronica? Veronica has experienced traumatic events. She's experienced negative alterations in mood as evidenced by persistent negative emotional state and markedly diminished interest or participation in significant activities. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Veronica has experienced intrusion symptoms after a traumatic event as evidenced by recurrent distressing dreams in which the content and/or affect of the dream are related to the traumatic event. Marked alterations in arousal and reactivity associated with the traumatic event as evidenced by irritable behavior and hypervigilance. The disturbance is not attributable to physiological effects of a substance. Veronica avoids stimuli associated with the traumatic event by avoiding external reminders that arouse distressing memories, thoughts, and/or feelings associated with the traumatic event, and the duration of the disturbance has been for 3 years. Now, how can we help Veronica and all those struggling with PTSD? What are some treatment options for PTSD? Well, there's cognitive behavioral therapy, cognitive processing therapy, cognitive therapy, and prolonged exposure therapy, which are all types of cognitive therapies which help come down to the core problem, the core trauma, and also alleviate the symptoms. There's brief eclectic psychotherapy, which combines elements of cognitive behavioral therapy with a psychodynamic approach. There's EMDR, also known as eye movement desensitization and reprocessing therapy, which is a structured therapy that encourages patients to briefly focus on the trauma memory while simultaneously experiencing bilateral stimulation, typically eye movement, which is associated with a reduction in the vividness and emotion associated with the trauma memories. There's narrative exposure therapy, which helps individuals establish a coherent life narrative in which to contextualize traumatic experiences, and there's also medications such as sertraline, paroxetine, fluoxetine, and venlafaxine, which are very helpful in the treatment of PTSD. Finally, here are the references I used throughout the entirety of the PowerPoint. If you go to the actual PowerPoint, you can see on the comments section under the actual slide which specific reference I used on each slide, which is very helpful if you're curious to see more information. Overall, I really want to thank you all for listening to my presentation, and I really do hope that you've learned something about PTSD. Thank you so much, and have a great day. Bye.